Hello, my name is Muhammed Assous. I'm a consultant endoscopic spine surgeon from Razi Spine Clinic in Amman, Jordan. The transforaminal endoscopic lumbar discectomy remains a rather difficult surgery to learn and master, and mainly because of the unfamiliar anatomy of the foramen to most spine surgeons, in addition to the fact that there is a number of different approaches to this particular procedure, which makes it quite confusing and difficult at times. So my plan really in this presentation is to pick a disc hernia at L4, L5 with certain conditions, which I might call the typical beginner's case, and take you through the surgical technique step by step. Hopefully, this will help you overcome the learning curve when you start this particular procedure and help you in your endoscopy career. This is my disclosure. Patient selection is absolutely critical, and if you select your first few cases correctly and wisely, you will definitely flatten the learning curve. And in my opinion, if you do transforaminal endoscopic discectomy, you soon enough will do most of the endoscopic spine surgery. If you learn this technique, you will do pretty much anything within the scope. But remember, you need direct supervision in your first 10, 15, perhaps 20 cases. Progress from the straightforward cases, like the one that I will take you through here, all the way to foraminal stenosis at L5S1 probably, and revision cases. Why do you need to master the transforaminal endoscopic lumbar discectomy? Because it, by no doubt, the least invasive discectomy approach available to us today. And it is the first step for you to master the transforaminal approach, which will open the door to the canal, as well as actually allow you to do all the pathologies inside the foramen. The basic indication of the transforaminal approach is foraminal, extraforaminal discectomies. That's the apparent indication for it, but I think there's much more to the transforaminal approach. It allows you to do most intracanal disc hernias, probably with the only exception of cranial migrating disc in men at the L5S1 level. But the advanced indications of the transforaminal approach, in my opinion, is the true value of this particular approach. So cases where there is a risk of neurological compromise or injury is higher. In example, people who have had posterior interlaminar surgery, like recurrent disc and lateral recessive stenosis after posterior surgery. These are beautifully done with the transforaminal approach. If you have a canal compromising huge central disc with neurological deficit, or coda equina for that matter, you can still do those with the transforaminal approach, avoiding further traction on an already compromised nerve root. Cases where the risk of iatrogenic instability and subsequently a fusion might be required, if the risk is high in those cases, like again previous posterior surgery, recurrent disc and lateral recessive stenosis after posterior interlaminar surgery, done with the open or the microsurgical techniques, in particular adjacent level disease with disc and lateral recessive stenosis, upper lumbar levels, where you might have to take the whole facet to decompress the lateral recess, or to take a large disc hernia out. If you go from the posterior approach, the transforaminal approach can do this without compromising the bony integrity of that particular level. And foraminal stenosis, which is often treated with fusion, you can do this with endoscopes, even at L5S1, without having actually to fuse that level, or at least defer the fusion surgery. Thoracic disc hernias, commonly calcified and can be nicely done with the thoracic transforaminal approach. Patients who have a high risk of GA, morbidly obese, elderly, frail patients who are not suitable for general aesthetic, can be done under sedation, conscious sedation with the transforaminal approach. So these cases, in my opinion, reflect the true value and the hugely added value of the transforaminal approach. Other important issues, my opinion, start in the prone position, and then you can do the lateral position, especially if you plan to do this under sedation, but start with the patients in the prone position. GA, no muscle relaxants, or only a small dose is given, so the patient can be intubated easily and safely. Allow 2 hours for the first cases. That should be enough, in my opinion. And try to work with the same team and never cut corners. So if you take one message from this particular slide, don't take shortcuts because you pay heavily for those. This is a precision procedure, and if you stick to the rules, you should be safe and efficient. Important factors for that beginner's case, disc factors, L4, L5. You could use L3, L4, but remember the dura is much closer to the foramen in L3, 4, so that will affect your reaming a little bit. So my advice is stick to what I tell you here in your first 5, 6 cases, and then you can easily expand the indication. So L4, L5. Non-migrating or low-grade migration is acceptable. Posterolateral paracentral disc is okay. That's ideal for you. The foraminal factors, exiting root should stay in the upper half of the foramen, and I'll show you what I mean by that. Normal foramen size, but please remember, normal SAP size. SAP hypertrophy has been a reason for people to abandon the transforaminal approach altogether, basically, because you cannot drill in your first cases. This is a totally different skill that you will acquire with time. So normal SAP size is of paramount importance when you select your first few cases. Patient factors, average build. You don't want somebody who's too thin, somebody who's too obese, because that will just add to the difficulty index of the cases when you start. And please, no revision surgeries, at least at the same level, because you'll have to deal with some adhesions, not like when you go from the back again, but there will be some adhesions and tethering of the root dorsally. So you need to avoid that when you start. So this is what I mean. So this is a good size foramen. Teach your eye to look at the foramen. You don't do that for posterior surgery unless you are dealing with foraminal pathology, of course. But in intracanal pathology, you will have to learn how to look at the foramen on the plain X-rays. This is a good foramen. Look at where the root is sitting in the upper half. The SAP is slightly big here, but that's still acceptable. That's no problem. Compare this to this one. This is L5 is one, the root in the middle of the foramen. This is exactly where you will be reaming. So don't start with a case like this one. This is an example where the SAP is huge. So if you cannot drill and burr the drill under vision with the shrill or with the drill, this is a non-starter. There's no way you could actually go inside the canal without actually burring the ventral part of that SAP. So start with something like this. Don't start with something like that or with a large SAP. So my advice, so just do the straightforward 5, 6 cases of L4, L5, paracentral, non-migrating or low-grade migrating is okay. And then fill in the gaps by expanding your indications. You can do L3, 4, L2, 3, L5, S1 even. You can start doing migrating disc, foraminal, extraforaminal disc. And then you can attack the recurrent disc, and in particular those with a tight lateral recess from a hypertrophic SAP. So the transforaminal approach really depends on the 2 routes that you can either serve or injure. So this is the craniocaudal approach that I will describe to you. It is safe because when you go in, let me remove the camera here. This is the amount of the SAP that you will. So this is L4, this is L5, this is the reamed SAP. They will land and dock your cannula in the lateral recess. So you will be in a close proximity to the traversing nerve root, and identification of the traversing nerve root will facilitate taking any disc hernia in the canal very safely, because that's the main structure that you might hurt, and that's the main structure that you will first identify. And I'll show you how to do this safely and efficiently step by step. The other nerve root, of course, is the exiting nerve root. And this is why when you land in the caudal part of the foramen, you are away from the exiting nerve root during access. So you protect that nerve root. Number two, you are as close as possible to the other nerve root in the rhesus, this traversing nerve root, and that will make life much easier for you to identify the disc hernia inside the canal. So a key concept in this procedure is to ask yourself, is the foramen my target, or is the foramen my passage door to the spinal canal? So am I doing a foraminal, extraforaminal disc, or a foraminal stenosis case? And we agreed we are not going to do any of this when we start, not for the first probably 10, 15 cases. You will focus on getting inside the canal from the foramen. So is this a posterolateral hernia, central hernia, migrating, non-migrating, lateral recess stenosis? You can do all those, but this is the one that we will begin our training with. So key steps in the transforaminal. So, I mean, 4 major steps. Number 1 is the needle entry point. Number 2, needle landing point. And then you ream the ventral part of the SAP to allow you to dock your cannula in the lateral recess. So you do this in all cases. The one that you begin with, the 3 steps are done under direct image intensification. And then when you get rid of the C-arm, this is the endoscopy part. Endoscopy part depends on a simple fact. You identify the nerve root, the compressed nerve root, to safely find and take out the disc fragment. And in our example today, we are talking about L5. So this is L4, L5 hernia in the rhesus, compressing the traversing L5 nerve root. And this is the one that we need to focus on. If this is a foraminal, extraforaminal disc, you will do this later. Then you will find the exiting nerve root, and in the axilla of it will be a foraminal hernia. A bit lateral to that will be an extra foraminal hernia. So needle entry point, you need to draw 3 lines. So the patient head is here. I'll show you the step-by-step in the video, which will hugely help you and improve your learning skills. So we need 3 lines. Head is here, the feet are there, basically. So for L4, L5, I need a parallel line, 12 centimeters from the midline. I need an AP line, I need the lateral line. So this is the most important part of the surgery, really. So decide the needle entry point. It is the meeting of these 3 lines, parallel, AP, and lateral. That's the needle entry point. How do you decide the parallel line? It depends basically on the level of the disc and the location of the hernia. But as a rule of thumb, for L1, L2, and L2, L3, remember, we are getting inside the canal to remove a posterolateral or a paracentral disc or a central disc hernia. But, you know, this is the rule of thumb. L1, L2, L2, 3, 8 centimeters. My parallel line is 8 centimeters from the midline. For L3, 4, I'm 10 centimeters from the midline. And for the commonest L4, L5, and L5 S1, you are 12 centimeters from the midline. Again, this is for intracanal hernias. As a rule of thumb, if I want to do a foraminal or extraforaminal disc, you take out 2 centimeters from these figures, and that's your parallel line. So if I want to do L3, L4 foraminal disc, actually 8 centimeters from the midline. But don't get yourself confused. You will have this as a reference all the time. So let's focus, please, on L4, L5. I want to go inside the canal in an average build patient. So I'm 12 centimeters from the midline, and that's critical. If the patient is too obese, you're probably 13 centimeters from the midline. Patient is too thin, you're probably 11 centimeters from the midline. So the AP line, so we decided on the parallel line. This is the AP line. AP line is simply from the superior border of the ipsilateral pedicle to the inferior border of the contralateral pedicle. I am always referring to the caudal pedicle. So the AP line and the lateral line, they both refer to the caudal pedicle, which is caudal vertebra, which is L5 in this example. So AP line, superior border of one pedicle to the inferior border of the contralateral one in a true AP projection. The lateral line basically is running through the posterior upper corner of L5, i.e. the caudal vertebra. It needs to touch the SAP. Remember, we will need to ream a little bit of the SAP. So I can do it like that, but then I will not be taking any part of the SAP. So you really need to be drawing the line in the posterior upper corner of L5. But remember, we need to take a sliver of that SAP to facilitate docking of the cannula and the recess. So this is my lateral line. You draw the AP line, pedicle top end to pedicle lower end, lateral line, which is basically posterior upper corner of L5 and a bit of the SAP. And I promise you, in 99.9% of the cases, they will meet in the average build patient at the 12 centimeters parallel line. I hope this makes some sense to you, not full sense to you, because if it doesn't, the video will show you exactly how to do that. But I need to cover the theory part, and this will, this will stay with you as a reference for you to refer to in the future if you like. So the needle, that was the needle entry point, the meeting of the three lines, the parallel AP and the lateral line. Now the second point, so I stick the needle in, and you need to land basically, this is L3, L4, I need to land on the posterior upper corner on the lateral view. Always remember, you insert the needle on the lateral view and you ream on the AP view. This is really, really important. Never ream on the lateral and don't advance the needle on the AP. So needle is inserted on the lateral. When I hit the bone, I'm happy with it. You flip the image intensifier to the AP and you should see that your needle is for L4, L5. This is L3, 4, but for L4, L5, your needle should be at the medial border of the pedicle. Reaming is slightly different, and this is why I advise you to start with L4, L5. So needle at the medial border of the pedicle for all the cases, that's absolutely fine. Reaming, and I'll come to that, is slightly different. So when I hit the posterior corner, upper corner of L4, the caudal vertebra in this example, I need to be on the AP at the medial wall of the pedicle in the recess. And this is the lower half of the Camden's triangle. And this is safe because you are far from the exiting and the traversing nerve roads. And this video will show you. So this is my needle landing point on the model here. So medial border of the pedicle, medial border of the pedicle. So if you imagine I'm going to do a lateral X-ray in that particular example. So it will look something like that. And when I do an AP view, it will look something like that. I'm at the medial border of the pedicle on the AP, but I'm the posterior upper corner of the caudal vertebra on the lateral, as you can see here. So needle on the lateral, needle insertion on the lateral, reaming on the AP. So I put a different slide because this is really important. Reaming, so we need to ream a little bit of the base of the SAP. And the reason you want to ream, because you want to open up the narrow caudal half of the foramen. As you know, that's the narrowest part. So you take a sliver of the ventral part of the SAP, and that will allow you to dock the cannula and the recess. So in this particular system, we use crown tip reamers. They only cut in forward position. They don't cut in reverse. So they are safe. They only cut in forward. And this is sometimes the amount of bone that you remove when the recess or the SAP is quite hypertrophic. So reaming also helps you actually to create a space for the cannula so that it stays here. So your left hand, if you're right-handed like me, so your left hand is actually free to hold. Your left hand is the scope holding hand, So it is not actually very busy when the scope is floating with the cannula and the foramen. So it also, so reaming helps you to anchor the cannula in the lateral recess. It has nothing, and I repeat, it has nothing to do with the freeing up any nerve roots, not the traversing, and certainly not the exiting nerve root. This is just reaming a little bit of the ventral part of the base of the SAP to facilitate docking of the cannula in the recess, full stop. So why we focus on the medial pedicle wall? Because 1.5 to 2 millimeters just past the medial pedicle wall, this is where you'll be reaming. That's where the shoulder of the nerve root, the traversing nerve root is. So be careful with that, please. So no reaming for L4, L5 in our example here. Just one, maximum 2 millimeters that past the medial with the pedicle wall is allowed for L4, 5, L5 is 1. L3, 4, the dura is more towards the foramen, so you shouldn't ream. I'm not talking about the needle insertion. The needle is at the medial pedicle wall, that's absolutely fine, but this is reaming. Please remember that. For L3, 4, you don't ream past the mid-pedicle wall. For the upper two levels and the thoracic spine, when you get to do those, you don't ream past the lateral pedicle wall on the AP, because you know the cord is just basically fills the medial part of the foramen in the thoracic spine. So this is just to show you the difference if I want to approach the canal or if I want to do something in the foramen. If I want, this is L4, 5, for example, in both hernias. So a posterolateral disc hernia, again and again, this is our example here. This is what I strongly advise you to start with. Pick a case like this one and do 5 or 6, and you will automatically get the confidence and the competence to progress from that indication. So for L4, L5, if I want to do an intracanal hernia, classical paracentral hernia, so I need to come a little bit shallow, as you can see here. So I need to go further from the midline. So this is my 12 centimeters. Remember, L4, 5, L5, S1, 12 centimeters for the average build patient. So 12 centimeters will take me to take a little bit of the SAP, and then it will allow me actually to reach the medial pedicle wall to go inside the canal. I will need to ream, so I have a more lateral entry point for the needle, 12 centimeters that is. I will ream the SAP, and my cannula will need to go inside. Just the tip of the cannula needs to be just at the medial pedicle wall, and my direction of the cannula obviously will be towards this hernia here. So this is again and again our example today. However, if L4, L5 is still my level, but the disc hernia is foraminal, extraforaminal, like this example, okay, I need to be closer to the midline because I need a steeper angle to reach the disc hernia. I'm not interested to go inside the canal. I'm outside the canal, so I'm only 10 centimeters for L4, L5. Do I need to ream? Absolutely not, because my hernia is outside. I will be using the floating technique, so there's no point actually reaming the SAP, unless if there's associated lateral recess stenosis and you want to deal with a hernia in the foramen or outside the foramen, and at the same time you need to access the canal, then you will need to ream, obviously, and look at the direction of the cannula, before you start work. So I'm outside the foramen or in the foramen, at the entry to the foramen, but not in the canal, and my direction is up as opposed to down, because that's where the exiting nerve root will be, and that's where is my target disc hernia will be. Okay, good. So the final step is really important, and please notice this. I said here, identify the target nerve root. I didn't say take the disc out. And this is simply because if you find the target nerve root, whether it is the traversing or if it's the exiting in cases of foraminal, extraforaminal disc, I promise you, you will almost immediately find the disc hernia. So focus on the structure that you might injure. Focus on the structure that you aim to decompress by removing the disc hernia or the stenosis or whatever you want to do. So find the nerve root in order to find the disc hernia. Remember, so this is the view you will see when you put the scope in. So you will see the pedicle, you will see the facet, and this is the traversing nerve root. You will need to find it and work a little bit. Once you find the nerve root, the disc hernia will be just ventral to it. Focus always on finding and identifying the posterior vertebral wall of the caudal vertebra, because that is the landmark between anything which is canal, i.e. dorsal to it, and the main disc, which you're not really interested in, i.e. ventral to it. So posterior vertebral line is your safety line. Remember that. And to me, this is really the most critical part of teaching TELD. People usually fail because they don't have the confidence of going inside the canal because they worry that they will hurt the nerve root. Well, the nerve root is compressed in the canal, so you really have to go inside the canal. The question is, how can you go safely and efficiently inside the canal and take any disc hernia, even if it's in the center, a big central disc, or even with a disc, inclined to other side, if you need to take it out? And the answer is, I identify the posterior vertebral wall. I put my instrument in a horizontal position like that. This is my forceps, and it just goes like this. And I'll show you in the video in details. And once you do this, you are safe, because remember, the nerve root is actually even pushed higher by the disc hernia, which enlarges the Cambrian triangle for you. So this actually helps you. So if you identify the posterior wall, you are safe. Just skid your forceps in a horizontal position. Take the hernia out, even from the center of the canal, without fearing of injuring the nerve root. And that is really important. So this is the beginner's case. This is a 47-year-old lady. So I'll take you step by step with the video. And hopefully this will help you, as I said, to start your cases to do transforaminal lumbar discectomy, endoscopic lumbar discectomy. So 47-year-old lady, severe pain and numbness, 5 months in duration, failed conservative treatment, and not really troubled with the back pain, although she has a mild scoliosis, as you can see here. She's really troubled with the leg pain. SLR is positive, a bit of weakness in the L5 distribution. And this is the disc that you will be looking at, and you will be looking at something similar to do. So foramen is okay. We can't see the foramen on this cut here. It's probably okay, but remember, this is the lateral, there's scoliosis, so we don't really know. So we need the foraminal view. This is the foraminal view, and this is absolutely critical. Train your eye to see the foramen on the plain X-rays, and most importantly on the MRI sagittal cuts. So remember, the foraminal factors are key to success or failure, God forbids, if you don't pay attention to that. Normal foramen size, this is a decent foramen. Is the SAP normal? Yes, it is. It is in the normal position. It is not like the example here, encroaching upon the foramen. And this is a disc you cannot reach if it's inside the canal without reaming this part of the SAP. You will be able to do that in due time, I promise you, and you will even enjoy it, but do not, please, do not start with it, okay? I've seen people fail because they list patients for transforaminal endoscopic lumbar discectomy, they counter drill, and they just took bits and pieces of the disc from here, left them in a fragment in the canal, and surprise, the patient wasn't any better. Did the surgeon open, and then the endoscope was bad, the endoscope was the culprit? No, it wasn't. Your patient selection was, I'm sad to tell you. So normal SAP is the root in the upper half of the foramen. Yes, sir, it is. So this is a great case for you to start. Pick something like this and do it. So this is the surgical technique. I'm gonna shut up now because it's all in the video. So I'll let it play, and I'll just nip for a cup of tea very quickly. So the patient is positioned in the prone position, as we can see here. So we will do L4, L5. posterolateral disc herniation on the left side, as I explained on the MRI. So the patient didn't have any muscle relaxants with induction. It is actually possible to give the patient a little bit of muscle relaxant with induction, but nothing afterwards, because you do need that feedback mechanism from the patient's leg if you happen to touch the root or come near it. So the procedure really it depends on the entry point for the needle and the landing point for the needle. So entry point of the needle, what I do is mark the midline here, and we will take 12 centimeters from the midline. This is the iliac crest. So parallel to the midline, this is my parallel line at 12 centimeters. And this is the first line we need to draw. The second line, as we can see on the X-ray, will be the AP line. X-ray, please. So the AP line will go from the superior border of the ipsilateral pedicle to the inferior border of the contralateral pedicle, as we can see on the view here. So this is the true AP. So I mark on the AP as it crosses the parallel line. So this is my first line, the AP line, top end of the pedicle on my side, lower end of the pedicle on the contralateral side. And I draw and extend the line towards the parallel line. Now we need this last line, which is the lateral line. Lateral, X-ray please. So the idea is that the AP and the lateral lines will meet at a point on the 12 centimeter parallel line for L4, L5. So the AP and the lateral line, which I will draw now, will meet at the 12 centimeter parallel line. And that will be our, this is my true lateral line. The patient has mild scoliosis, so we just accounted for that on a true lateral projection. X-ray please. I draw the lateral line, and then I press on the patient to keep my straight line here. And as you can see, the lateral line and the AP lines met at the 12 centimeter parallel line, and this is my entry point. So I'm inserting the needle, and remember, we always insert the needle in the lateral projection, and we ream on the AP projection, and this is really critical. So the needle I'm keeping in line with the AP line, and the foramen is more actually anterior than we think. So remember, the patient had no anesthetic, no muscle relaxant. So basically, I will feel feedback from the movement of the leg if we are near the exiting nerve root. X-ray please. So I'm hitting bone now, so I check on the X-ray. My trajectory is not bad. I need to go more anterior because I'm hitting bone, so I keep my craniocaudal trajectory. I just go a slightly more anterior angle. X-ray please. And that's a bit caudal, so I need to just modify that. X-ray. X-ray. Okay, so I'm in the posterior upper corner of L5. AP please. So I'm hitting bone, and now we need to check. We need to check on the AP, and ideally, if you want to go inside the canal, as indeed the case here, we should be at the medial border of the pedicle of L5. So all the landmarks are related to the caudal vertebra, which is L5 in this example. Okay. Okay, and that's okay. I'm right at the medial border of the pedicle of L5, so this is perfect. So I'm quite happy with that. So seeing the lateral and the AP views, so on the lateral, I'm in the posterior upper corner of L5, at the medial pedicle wall on the AP, and that's our landing point. So we decided the entry point, the meeting of the lateral and the AP lines on the 12 centimeter parallel line for L4, L5, and L5 S1. and the landing point will be in the posterior upper corner of L5 on the lateral, and at the medial pedicule wall on the AP. So that's the first step, okay? And then I'm going to do the wire exchange. And remove the needle. And we do the skin incision now. All what we need is 0.5 centimeter to 7-8 millimeters only. A little bit deep just to open up the fascia, and that's our skin incision for TELD. And we go for the first guiding rod, please. So this system here, picture please. Okay, that's very good. So I'm going to put all the dilators for soft tissue dilation. So the system here from JoyMax, we have the color-coded dilators and reamers. So we have the green sleeve here, followed by the yellow sleeve. As I said, this is only for soft tissue dilation. And then the red one, like in a traffic signal, traffic light colors. So green, yellow, and red. And then this is the stopping rod. So we always use that just to keep the first rod in place as I remove the yellow and the red sleeves. Thank you. Swap. So this is the reaming, and these are crown tip reamers. These are crown tip reamers, as you can see here. They only cut in forward position. And remember, as I said in the theory, reaming is safe, easy, and it's important if you want to access the canal, because you need to open up that caudal part of the foramen to go into the camber and safety triangle. So it's really important to ream that ventral part of the SAP. So they only cut in forward position. So the way we insert the reamers, anti-clockwise as we go in, you hit the bone, and then you need to press down so that you ream the SAP ventrally. So we need to go dorsal. This is why you drop your hand. Reaming is on the AP, remember that. X-ray please. X-ray. So I'm reaming to reach the medial border of the pedicle on my side. X-ray. Okay, and that should be okay. Remember, this is a young patient. She's 47 with a very good foramen, so reaming is minimal here. It's really to facilitate docking of the cannula eventually in the lateral recess. So remember, I've reamed for the sleeve reamer, so the green reamer went onto the green sleeve. So I pushed the green sleeve because it's already been reamed for. Now comes the yellow sleeve. And on top of the yellow sleeve comes the yellow reamer, as you can see. So reaming goes anti-clockwise as you go in, and you drop your hand so that you ream dorsally in the SAP. X-ray please. And every time I ream, my very good and experienced senior scrub nurse Malik, thank you Malik, is actually putting his hand on the patient's left leg, just in case if I touch or irritate that exiting nerve root, the leg will jump and he will feel it and we'll probably see it. This is extremely rare to happen, but it's just a precaution that you should do. He also is actually stabilizing the patient with his right hand, because as I ream, I will push the whole patient towards the other side. So his right hand stops me actually from pushing too much, keeping the patient in position. So again, X-ray. X-ray please. So that's, you can see, I'm approaching the medial border of the pedicle. X-ray, please. Okay, I get one lateral view, please, lateral X-ray. So I really just want to make sure that my reamer is in that posterior upper corner. I want to make sure that we're not breaching the disc, we're not inside the disc, or really in the pedicle. So I get one lateral view during the whole reaming process, which takes usually 5 minutes. X-ray again. Okay, and that's where we want to be. So we are reaming away, as you can see, away from the exiting nerve root, plenty of space for the nerve root, and reaming is only into the base and the ventral part of that SAP. So back to AP, please. We have one more reamer, the big red reamer. So again, I go with the stopping guide, push on it so that the first guide doesn't come out. The yellow reamer comes out, and again remember that I have already reamed for the yellow guiding sleeve, so I have to push it in, and then goes the red sleeve, the last one, and on top of it comes the red reamer, anti-clockwise as I go in. Push your hand down. X-ray, please. X-ray. Okay, so remember, the bigger reamer sometimes goes in much easier, so very, very carefully. X-ray, please. And that's it. You see, only a couple of turns, and because she's young, it's a big foramen, so reaming is on the AP, and you are allowed to bypass the medial pedicle wall for L4-5, L5S1 by 2 millimeters only, because beyond that is where the shoulder of the traversing nerve root. So be very careful with that. So we're done with the reaming. Again, the stopping guide is used to keep the first rod. Now comes the cannula. So this is the working cannula. I use the longer one. A couple of these on the Joymax system, but I like this one. And remember, the knob here, the handle, is directed towards the opening of the bevel. And this is the head of the patient. This is the feed side. So we need to stay away with the sharp end of the bevel from the exiting nerve root. So this is how we go in with the working cannula. So away from the nerve root, so the nerve root will come in that position, as you know. So the sharp end is caudal. That's it. And once I position that, I direct it up dorsally so that we will be looking towards the facet when we put the scope now. So, thank you. Hammer, please. What I do to anchor the cannula in a case like this one is just to hammer it gently in the recess. It stabilizes the cannula for you. It frees up your left hand, which is holding the scope. So just gentle tapping, and now the cannula is secure, and remember, it's facing up. X-ray, please. Now this is important. So my cannula tip is at the level of the medial pedicle wall of L5, so I know that I am actually in the recess. Give me a quick lateral view, and that will be the last X-ray for this procedure. So on the AP, it's very critical to always think where your cannula tip is. So on the AP, I am where I want to be in the recess, just medial or at the medial pedicle wall of L5. And on the lateral, you want to be exactly in the recess. So in that caudal part of the foramen, not in the distal space. This is all out technique. So the pathology is in the canal, so we're going to go in the canal in the recess. X-ray. Okay, wonderful. So away from the exiting nerve root, not in the distal space, on the lateral, and we are definitely in the recess. And that's the easiest way for us to put this scope and look at the anatomical landmark, the facet and the pedicle and the posterior vertebral wall. So we're done with X-ray, so thank you. So now I'm going to introduce the endoscope, and then we will follow everything on the monitor. And remember, this is the thesis endoscope. It has a 30 degrees forward angle. So basically, the knob of the cannula is looking up, so the opening of the cannula is looking up towards the facet. So the first thing I really should see with this angulation, and that's the way we hold the endoscope, is actually, okay, water, just a bit of wash here, and this is how you hold the transforaminal endoscope when the patient is in the prone position. Okay, so my left hand is the hand holding scope and the cannula controlling, so I can zoom in and out. So it's like a pistol, as you can see. I can rotate, I can do all the maneuvers with my left hand so that my right hand can do the work. So the index finger controls the zooming in and out, and it stabilizes the cannula at the same time. So I've put in the comments basically and the tips, but this is really important. So the anatomical landmark, as you can see, so let me just go back. So you will see the facet, and you will see the SAP. So this is cranial at 9 o'clock. Caudal is 3 o'clock. Remember, this is L4, L5. So L4 on this side here, L5 on this side here. Patient in the prone position. This is dorsal, and this is ventral. So dorsal will be the SAP of L5. Pedicle of L5 is here. This is where the posterior vertebral wall. You have to work a little bit to find that. This is the main disc, and this is the body of L4 in this example. Then use the radio frequency. Radio frequency is your friend. It allows you to shrink tissues, like this example here. I'm working around the posterior vertebral wall. I'm interested in this because I know this is my safety line. Remember, this is my safety line from here to here. And sure enough, that's the nerve root. That's the L5 nerve root here. This is the posterior wall of L5. This is the main disc, but I'm not interested in that. I want to go ventral to the nerve root to find the main hernia inside the canal. And indeed, that's the beginning of the hernia inside the canal. How do I know it is inside the canal? Because it is dorsal to the posterior vertebral and annulus line. So that's posterior to my posterior vertebral wall and annulus. This is all in the canal here. And because I can see the nerve root, you know, I'm happy because that is the safety of the procedure. So this is a fragment that's come out of the disc. But remember, this is a posterolateral disc hernia, so we're not inside the canal yet. And this is how you hold your forceps. In horizontal position, this is the 2 millimeter pituitary, basically. You can always feel with the radio frequency probe. And this is how you can go inside the canal. You go ventral to the nerve root because you know you are safe because you can see the nerve root. And this is why I prefer, and I'll always teach this technique, so you can see the nerve root, you can safely and confidently go ventral to it as far as the central of the canal to remove any central disc hernias, any migrating disc hernias, any calcified disc hernias, etc. Now, this is the PLL. You can see it here. This is the posterior annulus. Again, this is the posterior vertebral wall. So all this in that direction is very safe because this is subannular. This is inside the annulus, or subligamentous if the disc hernia is underneath the ligament. you can always reach, see, and take it out. And going deeper now inside the canal. That's a big fragment coming out. Again, just basically applying the same rules, okay? Parallel to the posterior vertebral wall, which is here, go all the way down. And this is the surgery endpoint. The nerve root is free, it's come down. There's no fragments when I feed with the probe, and you can see all the way inside the central canal, just ventral to the thecal sac. If you want to remove a foraminal fragment, this is the maneuver to see the exiting nerve root. You rotate 90 degrees anti-clockwise, you pull the cannula out a little bit, and sure enough, this is the fat overlying the exiting L4 nerve root in this example. And if you have a foraminal disc, this is exactly where you will find it. If there is an extra foraminal or a far lateral disc hernia, you need to go more out, somewhere around here, and even a bit further out to find it. This is why, remember when I said, if you want to take an extra foraminal disc, you need to come closer to the midline. So your 12 centimeter parallel line becomes, 10 centimeters. That's the root again free. And this is the muscle, closing in when you pull the cannula out. And this is the least invasive discectomy technique. Thank you so much. I really hope that this has been helpful to you. Pick your cases, properly, be safe, and be confident, because you know your anatomy and you know what you are doing. So this took 30 minutes really with the teaching and the running commentary. As you could see, she went home after 6 hours, virtually no leg pain, and minimal back pain. This lady came to see me from another country, and she was able to go back to her home country and fly on the day 5 post-operatively, and this is the fragment out. So take-home messages, really the transforaminal approach, in my opinion, is robust, versatile, and extremely powerful. It allows you to deal with issues inside the foramen, from disc hernias and stenosis into spinal canal problems like the lateral recess, and almost all disc hernias inside the canal. It does need good training, direct supervision. Remember, in your first few cases, persevere with it, and you'll be absolutely fine. But most importantly, adhere to the steps. And remember, your posterior vertebral wall is your safety line. And if you want to do this successfully and safely, aim to find the nerve root, and it will just lead you to the disc hernia. Thank you so much. Again, I hope this has been helpful to those wishing to pursue an endoscopic career and focus on the transforaminal endoscopic approach. Good luck, and thank you so much.